Merci tout le monde. J'habite à Montréal, je viens d'Angleterre et juste 20 minutes, donc je vais parler en anglais and that way I can get it done in time. So today I'm going to talk about the efficacy of exercise in the context of cardiovascular and pulmonary disease. Sorry, that's just my disclosures. And there's three things that I'm going to cover in this period of time. First is I'm actually going to talk about the efficacy, and specifically in the context of COPD, chronic obstructive pulmonary disease, and cardiovascular disease. I'm just getting my timer going so I know how long I have. Okay. And then I'm going to talk about questions around the type, frequency, and intensity of exercise, and use hypertension, so high blood pressure, as an example. And then just talk briefly about future directions, and specifically around adherence and maintenance of exercise in the context of chronic disease. So just very briefly, for those that don't know, COPD, this is an obstructive lung disease that develops over time. Smoking is the number one risk factor for it. And if you look at the bottom, you see the two sort of classic phenotypes, the pink puffer and the blue bloater. And as this disease develops, it becomes very difficult for people to actually be functionally active. And pulmonary rehabilitation is one of the key interventions that works quite well, as you will see. In the context of cardiovascular disease, I'm going to be talking about post-myocardial infarction, so post-heart attack, post-revascularization. So on the right-hand side, you see just a picture of an artery being opened up. So this is where there's a lot of blockage and not a lot of blood's getting through. And in the bottom, the cartoon, that represents heart failure, which is a very progressive process that normally follows heart attack. And you're left with a very sort of big, saggy heart. So I'm primarily going to talk about exercise in the context of these two diseases in terms of efficacy. So there's a lot of studies that have been done looking at this, and we're very lucky because the Cochrane review groups have done a pretty good job of assimilating all the data that's out there, and I'm really going to just walk you through some of the Cochrane review stuff and identify sort of where the quality evidence is and where we still have some room to grow. So McCarthy et al. Just updated the pulmonary rehabilitation Cochrane review. And one of the members of this group is a physician named Yves Lacasse, who is in Quebec City. And I was at a meeting recently, and he was very proud to say that this review has now been officially closed. So in Cochrane terms, what that means is they feel like there's sufficient evidence around this specific topic that they don't ever need to do another review again. Now, some of us debate whether that's a good thing or not, or the appropriateness of that, but that's a discussion for another time. But what this review looks at is pulmonary rehab versus usual care or medical advice. And in the context of pulmonary rehab here, the primary intervention segment is exercise, though I will declare that there are some elements. Some programs do other things than just exercise, but the vast majority of this data relates to exercise. And in this particular review, they're particularly focused on quality of life and functional and maximal exercise capacity. So, in the context of COPD, it's a degenerative process, and really a great deal of effort is focused around improving quality of life in these patients. You're certainly not going to make them better. There's no reversing of COPD, and trying to make them more functionally better off. So the good news is that across the 20-odd studies with over 1,000 patients in them, when you look at the effects of pulmonary rehab, you see a very nice increase in quality of life. These are two standard questionnaires, the chronic respiratory questionnaire and the St. George respiratory questionnaire, which are used to measure quality of life in this kind of population. If you look, so one thing I'll tell you, that the CRQ higher score is better. Just to confuse us, the St. George, a lower score is better. So if you look here, what you see is in the treatment group, you get an improvement of about 0.8 with the respiratory, the CRQ, and a reduction, which is better, of about just nearly 7 points. The minimal clinically important difference, so this is the value of change that we see that actually translates into people having a better life and better outcomes down the line. If you see that both of these values are well above the minimally clinically important difference. This is a good story, it's good news. Exercise works to improve quality of life. And when we look at the functional measures, and this is an incremental shuttle walk test, a 6-minute walk test, and cycloergometry. They're all various types of exercise tests, whether they be maximal or submaximal. What we see is significant improvements across the range of studies. Interestingly, there's a second Cochrane review that actually looks specifically at sort of harder endpoints, so hospitalizations and mortality. And unfortunately, there's a much smaller amount of data here. So as you'll see, in the previous review, we were talking about 19 studies with over 1,000 patients. Here we're talking about 5 studies with 250 patients for hospitalizations, 3 studies for 110 patients. So much smaller amount of evidence. But the good news is that there is the pulmonary rehab actually translates into a reduction in hospitalizations and a reduction in mortality in patients with COPD. What's particularly impressive about this particular slide is these numbers here. So the numbers needed to treat. And so this is the number of patients that if you treated, you're going to prevent 1 additional event. So you only need to treat 4 patients to see a reduction of hospitalization, 6 patients to reduce mortality. These numbers are really quite impressive, and there's a few medications that are as efficacious as this. Just to reinforce what we saw before in the previous study, you see a lovely effect with quality of life and with functional capacity, though not for all measures. So I just highlight those 2 because they're not actually statistically different, but they're trending in the right direction. On the cardiac rehab side of things, so this is a similar scenario. So cardiac rehab is generally, virtually all cardiac rehab programs are exercise-based, and some may have some additional components to them. There's a much longer history of cardiac rehab, and Cochrane, it's now got to the point where Cochrane has done a review of reviews. So as things unfold, we get more complex in many ways. And just last year, Anderson Taylor published the review of reviews looking at cardiac rehab. And in total, these 6 reviews cover 150 RCTs with nearly 100,000 patients in them. So there's quite a lot of evidence here that we're going to go through. I'm going to focus on 3 specific reviews. So this is primarily looking at exercise for heart disease. So that's in the context of those people post-heart attack and those people that have had that revascularization, where you're opening up the arteries to improve blood flow. And then those for heart failure. The column on the far right-hand side, I've kind of put that in there just for interest because it's looking at home-based versus center-based cardiac rehab. So those people that come to the center and are directly supervised, very hands-on, versus those that are supervised from a distance. And there's some interesting information that comes out of that. So as you'll see, we have a lot of data, nearly over 10,000 patients looking at exercise for heart disease, about half that for heart failure. Of the studies, you'll see that there's still quite a large proportion that have exercise only as their intervention. And then these indicate those studies that have exercise plus one other thing. It could be a variety of different things. Most studies on average are small. They range from 3 to 6 months in general. And we follow people for a very short period of time, really. Okay, so what's interesting here? So first thing, hard outcomes, mortality. This is, one of those things that physicians definitely like to focus in on and gets most of the attention. What's interesting here is if you look, the only thing that is statistically significant is the one that's in bold. So long-term or medium-term mortality post-exercise for heart disease has an effect. But if you look at the confidence intervals of short-term mortality for that and the parallel medium-term mortality for heart failure, we're talking about margins of error that are very, very small. But there seems to be effect. When you look at difference between home versus center, there's no statistical difference between either of those two. They're both efficacious, seemingly. Hospitalizations, interestingly, we see a benefit short term, but not in the medium term. With the exception being when we look at specifically heart failure related hospitalizations in patients that have heart failure, we see a dramatic drop in prevalence. So that's so unsurprisingly, when you have patients with heart failure, you give them an exercise intervention, has a big effect on their heart failure outcomes. Finally, just to show you that quality of life is also changed in a positive way, and that there's no difference between home and center-based. Also, interestingly, there's a number of studies that have looked at factors, secondary factors, not just these hard endpoints. And what you see is in patients with heart disease, the cardiac rehab, so exercise-based interventions, tends to reduce cholesterol, reduce triglycerides, and reduce blood pressure. Interestingly, does not increase HDL, which is not what we see in non-disease populations. We tend to see HDL increase. So there's some potential mechanisms through which we can understand how this might work. So, really, this slide summarizes the main points of the efficacy side of things. So I'm even quicker than I thought, but I have more. So in COPD, we see a medium-term benefit of exercise or mortality, short-term benefit in hospitalizations, parallel with heart disease and heart failure, some benefit of heart failure-specific hospitalizations, and both fitness and quality of life improve. So the simple answer in terms of efficacy in a cardiovascular and respiratory populations is that exercise seems to be pretty good. And if we stop there, most people would be pretty happy and we could pat our backs and leave. But that's not the whole story. Exercise is, as I'm sure you all know, exercise means many different things to many different people, and you can do exercise in many different ways. And so one of the interesting questions starts to be, not only is exercise efficacious, but how is it efficacious? What's the optimal structure and optimal pattern that we might see? So I'm just going to use hypertension as an example because there's a lot of interesting work that's been done around blood pressure and increases in blood pressure, which is one of the key risk factors of cardiovascular disease, and how exercise, different patterns of exercise influence blood pressure. So I'm going to start with aerobic exercise. So this is the classic large muscle group, dynamic activity that most of us are used to when we think of exercise. It's running, cycling, things like that, swimming, and so on. The very first systematic review that was published around blood pressure was by Hagberg in the late 80s. And these values were amazing. You could get a drop in, according to this study, you get a drop in systolic blood pressure of about 11 millimeters of mercury and a drop of about 8 millimeters of mercury. And this is twice as good as virtually any drug that you can find. And so everyone was amazed. And the American College of Sports Medicine, which is the largest sort of sports medicine, exercise science group in the world, took these numbers on board and published it in their guidelines and really pushed for this. What you realize is when you dig a little more deeper into the data, that the trials weren't actually that good. And when you start to do better quality trials, what you see is a significantly reduced effect, but still quite an important effect. So our understanding at this moment in time is that around about a 3.5 to 2.5 millimeters of mercury drop in blood pressure that you can get with exercise. So that's good. That's about equivalent, almost equivalent to a drug, a little less than one medication. Okay, so aerobic exercise works, but what kind of pattern of aerobic exercise is important? So this is an analysis done by Wallace quite a while ago, and it's been repeated a few times, but and the same pattern comes out. So what we have here is a plot of change in blood pressure. So the lower this goes, the better the exercise is doing, and then various different markers of exercise. So here we have frequency. How many times during a week do you exercise? Duration. When you exercise, how long do you exercise for? And intensity. When you exercise, how hard do you exercise? Okay. Interestingly, what you see is that frequency and duration, the more you do, the better it is. Whereas intensity, actually, the more you do, the benefit is not quite there. So what they did was they broke down these 30 randomized controlled trials and tried to ask the question, what's the best combination and duration of intensity to reduce blood pressure? Okay. So the good news is I have the slot that's after lunch, so everybody's a little bit sleepy at this point in time and not quite awake. So I'm going to get you a little bit active at this point in time, aid that digestion process. What I'm going to do is I'm going to ask everyone to stand up at this moment. Stand up. There's a really good study from Australia that shows that for every 20 minutes you sit, you should stand for 2 minutes with a benefit. Okay. Now what I'm going to do is I'm going to go through the 4 answers. If you think that the answer is correct, I want you to sit down. Okay? So this is not raising the hand, this is sitting down to the correct answer. So which is the optimal duration intensity if we exercise someone 3 times a week? Is it A, 15 minutes at 50%, so that's low duration, low intensity? All those things, that's correct, sit down. Okay. B, 45 minutes at 50%, so high duration, low intensity. All those things, that's correct, sit down. Okay. C, 15 minutes at 70%, so low duration, high intensity, sit down. And then those people that like to make people work, 45 minutes at 70%, so high intensity, high duration. If you think that is it, sit down. Anybody that's left standing, you missed something. Okay. So, yeah, those at the front table were excused. So the answer is high duration, low intensity. Actually, this is moderate intensity. And what you see is the greatest benefits are driven by doing exercise for longer, but not at a more intense level. Okay? Now, this is interesting because it contrasts what we know about healthy people and what we know about changing other markers, where higher intensity and higher duration actually has a greater benefit. I have to be honest and say, we don't yet know why this is. But the point is that it's important to think about when you deliver exercise programs, what is that optimal pattern that you're looking at? And maybe you need to do some trialing to find out what that is. Exercise also comes in different styles. So you have what I described as the aerobic exercise, but you also have something called resistance exercise. Okay? And we have 2 kinds of resistance exercise. We have dynamic resistance exercise. So this is, where we go to the gym, we lift weights, we use bands, but we're using resistance, we're pushing against something, but we're doing it dynamically. So we're moving legs, moving arms, moving body parts. Isometric exercise is where you push against something and then you hold it. So So there's no movement, okay? And this was just me earlier exercising. I thought I'd, in my dreams. Okay, so interestingly, we now have some data that starts to look at the effects of resistance exercise and dynamic versus isometric in the context of high blood pressure. So the very early stuff, as you'll see, is somewhat optimistic, that we get these really quite nice patterns of blood pressure change. You'll notice, so Fagard and Cornelissen, who are in Belgium, are the masters at generating meta-analysis around blood pressure. And you'll notice their 2013 meta-analysis has less studies in it than their 2011. And this is because they started to partition out the exercise a little bit more. And you see that when you start to partition things out, the effects tend to drop a little bit. In parallel around resistance exercise, we actually did a meta-analysis as well, and we were very strict in terms of what was included. And the stricter and more concise you get in terms of studies, you start to see a questionable effect of resistance exercise, a dynamic resistance exercise. Parallel that, though, to the isometric exercise, and you see very, very large effects. Now, this is from small number of studies, small number of participants. So as the studies grow, both in size and number, this might shrink a little bit. But it's interesting to see this parallel between what is resistance exercise, but dynamic versus isometric. And just to contrast that with aerobic. So just briefly, not all exercise is created equally. Different disease states might require different optimal patterns. Finally, I'm just going to this to be very quick, go through some potential future directions. So, exercise is one of those things that we all probably prescribe as being good. I've showed you efficacious or data that the efficacy is high, especially in those with chronic diseases. But we know that most people don't, or a lot of people find it hard to engage in exercise and they find it hard to maintain. And we have data that demonstrates that. This is cardiac rehab data, where about 60% of those people that come into cardiac rehab, which is a fraction of those that should get into cardiac rehab, about 60% complete. When you look at completers, those completers are only doing about 80% of all sessions. When people stop going to cardiac rehab and we look at their exercise patterns over time, what we see is that about half of them maintain their exercise, about a quarter of them still do some exercise, but intermittently, and about 30% stop altogether. Okay, so this is a problem. We also know from the literature that greater adherence equals better outcomes. The more exercise you do over time, the better off you are. Okay. We also know there's some predictors of poor adherence. Age and sex are predictors, but they're inconsistent predictors. Various studies show in various different ways. There is a series of risk factors. Worse risk factors tend to relate to worse adherence. Obviously, if you have low illness perception or low self-efficacy, unsurprisingly, you are less likely to adhere. One of the best and most consistent predictors is high depressive symptomatology. I just want to show you this one graph because I love it. This is pulmonary rehab, but it maps onto cardiac rehab as well. What you see here is along the bottom, increased depressed mood with probability of completing. And it's these beautiful linear lines. The higher the depression scores, the lower the attendance. What's interesting here is it's overly pronounced in women versus men. Okay? That's a whole nother talk, but these are things to think about. There's been a Cochrane review on this, 8 studies, over 1,000 patients. Of the 8 studies, here's the mixed mash of things that have been interventions specifically delivered to try and improve adherence in cardiac rehab. Self-monitoring and problem-solving coping strategies are the most common. These numbers add up to more than 8, so obviously some studies are using multiple studies. This mismatch of approaches leads to a mismatch of data. Of those 8 studies, you see that 3 that are in black actually have had some degree of success, measuring adherence in many, many different ways. And what do those 3 studies look like in terms of what they used? Well, we have goal setting, feedback, problem solving, positive reinforcement, action planning, and self-monitoring, which is a bundle of different stuff. So the upshot of this message, okay, is that we don't have a real pattern to understand how we can improve adherence in these populations. And this is just a smattering of things that people have tried. And obviously one of the key elements that we really have started to focus on within our group is looking at issues around internal motivation and increasing internal motivation. And most of these don't directly target that. So there's a big area, right? So we know that adherence is important because it relates to better outcomes, and we really don't know what's going on there. So there's a big area and a great cross-disciplinary area that we really have to start working more on. So in summary, efficacy exercise for clinical outcomes. So in cardiovascular disease, I think for those hard clinical outcomes, the evidence is good. For COPD, the evidence is promising for the hard outcomes. For the quality of life and the functional stuff, it's very good. Coming back, type of exercise, different patterns, different states. You've got to work out what's optimal. Adherence, generally very poor. But the good news story in that is that when you look at adherence to things like cardiac rehab and maintenance particularly, post-rehab maintenance in the research studies is still poor, and yet we still see this benefit on mortality. So in spite of poor maintenance, we still get a benefit. But could you imagine if we improved that? What kind of extra benefit and extra bang for the buck would we get? But how do we do that? That's a question unto itself. Thank you very much. This is my lab who make this possible, and then just finally my acknowledgements to all the funders and collaborators that I work with. Thank you. Merci.